Hi, good afternoon, everyone. I guess we can get started. So welcome everyone to our April 3rd VLC session entitled Viral Hepatitis Elimination Plan Implementation, made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs, manager on the hepatitis team. And today we have our presenters, Tennysa Mace with the West Virginia Department of Health and Human Resources, and Andrew Knox with the New Mexico Department of Health, and our moderator, Lauren Orkis with the Pennsylvania Department of Health. For today's session, the format is as follows. We will have a presentation by Tennysa and Andrew. Oops. Okay, I don't know, that's weird. And then we'll have a moderated discussion led by Lauren. So feel free to use the chat to introduce yourselves and your jurisdiction. And if you all have any questions for our presenters today. So with that, I will turn it over to Tennysa to get us started.
Okay. Where are we on the? Okay, there we go. Can everyone see that? Yeah, okay. So my name is Tennysa Mace. I am the Viral Hepatitis Prevention Coordinator with, we have recently changed to the West Virginia Department of Health in the Bureau for Public Health. So our elimination plan development, I'm going to talk about how we got to where we are right now a little bit first. We did a joint HIV and hepatitis C elimination plan. Because our HIV and HCV programs are within the same division, we share the same stakeholders and experts, and it gave us the ability to leverage funds for plan development. And this is kind of our plan timeline. So the real work started in June and went from June to November. So it was a pretty quick development. So because we collaborated with HIV, the plan is structured using the National HIV/AIDS Strategy Pillars: prevent, diagnose, treat, and respond. So prevent, of course, just preventing new infections. Diagnose, focusing on increasing the number of healthcare providers who know how to correctly diagnose, and increasing public awareness. Treat, just to increase the number of people with HCV who are cured. And again, a lot of that focuses on improving healthcare provider awareness of hepatitis C cure. And respond, just to respond quickly to outbreaks. So these were our key stakeholders. Everyone from people with lived experiences to other departments with other state agencies, so like the Bureau for Medical Services, Department of Corrections. We also had state medical associations, community and faith-based organizations, homeless coalitions. So these same stakeholders that developed the plan, you'll see in a minute, are responsible for implementing it. So this is our elimination plan. The page where you can find it at that QR code if you're interested in seeing the whole plan. So part of our implementation and monitoring of our elimination plan is the role of the Hepatitis Elimination Technical Advisory Group, or our HETAG group, that is part of our grant funding. There was a lag in the time from when the plan was finished to when the task forces started. So in the meantime, we were able to get the HETAG to focus on sort of those plans that, you know, a lot of the plans in the elimination plan also went with our work plan for our grant. So they were able to focus on those activities. It kept the momentum moving forward, so that there wasn't, we had everyone involved and passionate about everything while we were doing the plan. So this sort of kept them involved. And they meet quarterly, sometimes bi-monthly, with updates on goal activity, and to discuss how we're going to move forward with the next priority goal. So the elimination plan task forces, they were created out of the subcommittees that helped develop the plan. So again, we have a plan, prevent, diagnose, treat, and respond. Or prevent, diagnose, treat, and respond. So those task force goals are to facilitate completion of the plan activities, to reach the overall goals for each pillar, and to provide updates to key stakeholders for monitoring. Those expectations for them include meeting no less than once per quarter. They are also, I think, usually meeting monthly or bi-monthly, providing quarterly progress update on activity process measures, and they sort of create their own timeline for implementation of activities. So because we were sort of starting mid-year, some sort of initial focus given to the task forces for prevent, provider education, for diagnose, implementing testing and all quick response teams, for treat, to increase federally qualified health centers providing integrated care, and for respond, data dissemination in the local health department response plans. Those were just kind of recommended starting points for them. They have kind of taken off, and as we want them to do, and are spanning out. So the Prevent Task Force implementation and monitoring focus is on the health systems clinics implementation of EHR, mobile services provided through syringe service programs, training of HCV prevention best practices for community and faith-based organizations, implementation of prevention best practices, and implementation in high-risk populations. The Diagnose Task Force implementation is expanding HCV testing in non-traditional settings, opt-out testing in health and correctional facilities, HCV testing offered through QRTs, development of diagnostic curricula for health profession students and trainees, participation of clinicians in our collaborative learning programs, such as the West Virginia Hepatitis Academic Mentoring Partnership and our Project ECHO, and educational campaigns that reach policymakers, patients, and the public. The TREAT Task Force is responsible for development of curricula on HCV clinical management, including social determinants of health and addressing stigma, participation of healthcare providers in collaborative learning programs, as they are in Diagnose, educational campaigns on HCV therapies, curative treatment for HCV in non-traditional settings, and private practice physicians offering HCV treatment. So a lot of their implementation goals focus on getting providers into those mentorship programs. And Respond is just completion of local assessments and response plans, annual reviews of the response plans, increase of HCV surveillance staffing resources, and data sharing. Respond is more focused on HIV than hepatitis C, just because of the numbers of hepatitis C in West Virginia. So our challenges in elimination plan implementation and monitoring: because we have a shared plan, it can mean the focus leans toward HIV. So we have to be sure that our hepatitis C champions are present and always making sure that we do not get lost. The length of time between development and implementation, as I mentioned earlier, meant building momentum again. So we had to sort of like bring out that passion in people again to get together. Continued engagement of people with lived experience, which is always a difficulty, making sure their voices are heard, and shifting plan, objective, and activity work to the stakeholder agencies. One thing that was brought up again and again while we were planning is that all of the work cannot be put on on the hepatitis team and the HIV team at the state. So really making sure that people take ownership of their participation in implementation. So our current status, the implementation and monitoring kickoff meeting was held in September of 2023. The task force development was from September of 23 to January 24. The task forces began meeting in February, and the first monitoring report will be in June. So as you can see, they are just getting started, but they have taken off. And this is my contact information. I also included Elena Hudson because I will not be in this position much longer. So if you have questions, you might want to send them to her. So she'll be able to take care of those for you. And with that, I will pass it back.
Thank you so much. Yeah, go ahead, Andrew. Yeah.
Cool. Okay. Let me get my slides up and get all set. Begin. Can you see that? Good. It's not on the first slide.
Yep.
Hi, everybody. My name is Andrew Knox. I'm the viral hepatitis coordinator at New Mexico Department of Health as part of the viral hepatitis and harm reduction integrated program. First of all, I want to thank Tennysa for going first, and Zakia and NASDAQ for inviting me on this call. I'll do a quick land acknowledgement. This week we're having our community planning and action group, which is our summit for the year for HIV planning. And so I'm coming to you from Espanola, New Mexico, which is in northern New Mexico, a little bit north of Santa Fe, from the Oke-Owinge Pueblo, where we're having our planning meeting. So I'm cutting out of that meeting so I can do this. Glad to be with you today. I will discuss our elimination plan and our process. Before I do, I have to tell you, given us a letter to officially approve of our plan. I don't know, it's not well known, but she was actually our health secretary before she was governor. So we've gotten really good support from the top to the bottom. The group that convenes to do our planning and is now doing just monitoring is called the End Hep C and M Coalition. The C is red because to kind of echo Project Echo, if you're familiar with Project Echo, is a project to do force multiplication where we had a dearth of providers who could treat hepatitis C. And we'll talk a little bit more about that later. But we meet every 2 months. We've been meeting since 2021. The group was originally formed in 2014, and so this is actually our third hepatitis elimination plan. This one we think is going to make a big dent in a way that we couldn't do before. So we have the Medicaid MCOs on our calls. Corrections department comes. We have a New Mexico Peer Education Project, which is groups of people who are incarcerated who educate their peers on getting treated. And we do have a project I'll talk about that allows that to happen while people are incarcerated. We have our infectious disease and epidemiology folks on our calls, Project Echo, and folks from the University of New Mexico always join us, as well as some providers and health educators from our various regions. And we even have folks from the industry who come on to our call and they're very supportive of what we're doing here. So let's see. So we have taken a strengths-based approach. So as you know, New Mexico is not the wealthiest state in the nation. So we looked at what we could do with the resources that we have. So Project Echo is really a big asset for us. Dr. Aurora started in about 2012, I believe. He was an infectious disease doctor and hepatologist. What he would find is people would come visit him who were well down the road with cirrhotic episodes with their livers, and a lot of times he couldn't treat them because it was too late. And the reason was a lot of people were in a rural frontier state, so a lot of people would have to drive 3, 4, 5, 6 times, 3 hours to get to the doctor. And they would put it off and put it off, and he was tired of seeing that happen. So he started with video conferencing technology that was not what we have today, big machines, and started working with primary care providers around the state to just do sessions where they share how to treat these cases. And of course, those have improved over time with the DAAs coming out. And so now we have, providers all over the state who are primary care folks and even nurse practitioners who can treat and just about every part of our state. So we're making a lot of progress there. We also, in 1997, were given permission to start a harm reduction program. So we've been going for 25 years there. And I'll talk a little bit more about that as well. In 2020, we were given $22 million by the legislature to form a partnership between NMDOH and corrections. We actually register the patients with NMDOH, which makes them 340B eligible. And we're able to purchase those medications for people who want to get treated while incarcerated. And we don't have to pay nearly the price it would cost if we did it retail. And we have, a great Medicaid program that has, for a while, we're a little bit behind right now, but a lot of states have caught up to us in eliminating barriers. But we were originally pretty early on in getting people treated without too many barriers. And we just eliminated the prior authorization requirement for most patients, unless they're complicated. And so we're making progress on making it easy for people to get treated. We also have created some programs called where we know even with good Medicaid, there's still a few people who don't qualify for insurance, either somebody who maybe declined their insurance to their employer or is undocumented. And so we're able to cover them with our medical insurance pool, which is the high-risk pool that's still maintained by the state. So we can actually pay for their premiums for up to 6 months. And if they use our contract pharmacy, we can even provide them the medications at no cost. And then, of course, one thing we've noticed in the past couple of years is with our harm reduction program, people stopped coming around 2021. And we were, not distributing as many syringes. And we realized that when people using more fentanyl instead of heroin didn't really want to inject it because of the danger. So they started smoking and snorting it. We were given a legislative authority by our legislature to change what we do within the program and supply safer smoking kits, safer snorting kits, and a whole bunch of other things that anything that we can do to reduce the risk for overdose and reduce the potential for transmission. So we give out all those other supplies that we couldn't do before. And then, of course, it's important that we track our progress with an epidemiologist and collecting of lab data. The way that we modeled it, we didn't have up-to-date data exactly. So we just kind of did back of the envelope modeling. So between the strategies that I just listed, we estimated that there are about 64,000 infections in our state. We sort of accounted for clearance rates, previous cures, et cetera, and then the various aspects and ways that we could get people treated. We came up with a number just short of 26,000 people. And if we were able to get 4,500 people cure a year, we could get that down pretty close to 0 by 2030. I don't know if we're going to make it, to be honest, but we are hoping that some of the shift away from injecting will help us, at least on the infection rate side of it. We analyzed our data, and this is only up to 2019, and we're working on getting some more up-to-date numbers. But essentially what we have is 2 different cohorts. We have our older cohort, which you call the baby boomers, largely are on Medicaid by this point. And we did a project called U30 to demonstrate that we had a lot of people under the age of 30. And that was done 7 or 8 years ago. So now they're all under 40. But those two core cohorts are the two that we have to focus on. And then we of course looked at our infection rates and whether those are trending up and down. And I mentioned that after 2020, we are expecting a little bit of a downturn, at least since fewer people are injecting substances and turning to safer modes of injecting or ingesting substances. So some of our key elimination programs talk about harm reduction. 1997, we've been going for quite a while. We've also been able to expand services beyond just supplies. So of course we give out naloxone, but we're also, there's a strong encouragement by our political leaders who want us to start looking at homelessness and seeing the people that are most vulnerable and most visible and addressing those needs. So we're starting to collect data on what other services people need, whether it's housing, IDs, just any other social services, even just food. And so we're starting to track that, and certainly referrals to treatment. And we're going to start offering MAT in all of our public health offices. That's been ordered by the end of the year. So we want to establish a strong linkage to care mechanism within our harm reduction programs. And by the way, there are 40 locations in public health offices, and we now have 26 community partners that are doing these services. We also have funding to start doing more medical and actually mobile services, where we're not just having offices in different locations. Some of those locations aren't even advantageous. Like one of them is in front of near a sheriff's department, so people don't want to come to that. But if we can take our services out to the communities, and we have a lot of rural communities, so driving out to somebody's home, showing up with syringes, showing up with Hep C testing and treatment, et cetera, is a strategy that we're going to be using a lot more. Again, I talked about Project Echo and how important that is to be able to multiply our force in terms of who can treat hepatitis C around our state. And of course, I discussed the treatment partnership with NM Corrections Department, which has really been amazing. They didn't even have the capacity to treat more than about 100 patients per year. In the first year, they upped that to 600, which was our goal. And then they're currently headed for 900 a year. So the only limitation there will be the money and we may ask for another appropriation if we get favorable results from this program. We also discussed Medicaid. Over 40% of our population in New Mexico is Medicaid eligible. And so that's a major mechanism for getting people treated. And also 40% of folks who come into incarceration are hepatitis C positive. And so we kind of realized that if we could help people get treated while they're incarcerated, when they come out into the community, they'll be healthier. They'll be more likely to potentially stay in recovery and have the energy to do so. And then Project Heat I discussed, which is it's a very small program at this point. If we didn't have expanded Medicaid, we'd have a lot more people that were uninsurable. But the number is small, but we certainly want to reach into the populations that cannot otherwise get treated. And then the Peer Education Project. I want to discuss that a little bit. What it is people from Project Echo get on monthly calls with volunteers in our incarceration or facilities, and they discuss various aspects of hepatitis C, treatment, key living skills that sort of support health around hepatitis and substance use. And then they educate their peers to come get treated and how to not transmit the virus. That includes things like, unlicensed tattoos, substance use while incarcerated, et cetera. And then some of them have come out back into the community and then joined Project Echo directly to continue the program. Really cool. And sometimes they participate in our planning meetings, and they provide valuable. And some of the, I'm about to show you a slide here. Right on the right, this green graphic is based on a banner that they made. And so we turned it into a poster that we can display in all of our harm reduction locations. So we also consider treatment as prevention. And also the other thing that's cool about our harm reduction program is it really provides a right to syringes in New Mexico. So even if you can't go down to your Walgreens and get, maybe you have a pharmacist that doesn't want to sell them to you, you can always come to one of our 66 locations and get those supplies that you need. We also focus, we have another, this is outside of our program, but alcohol is a big driver of certain behaviors. And so we do focus on trying to reduce alcohol use in our populations that are affected. And then we've done testing for many years. We look forward to having better testing that's confirmatory on the spot, as the CDC has told us they're trying to get. But we still do harm reduction based testing for anyone who thinks they might have been exposed. And that leads directly. And the other thing is some of our harm reduction locations are either FQHCs or community clinics, and they may have a nurse and provider that can do the treatment right on the spot. And then we're also adding those mobile clinics, which we really hope will help provide test to treat modes as soon as the testing technology gets just a little bit better. And as I said before, our injected drug use has declined literally by 80% in the last 3 years. So we think that will have a positive effect on our infection rates. And the peer education is very important as well. I've already talked about some of these details in harm reduction, so I'll skip this. But one thing that we do really well with harm reduction is it's not about the supplies. It's about the relationship that we build with each of our clients. And we have about 15,000 every year, individual clients. And so we really talk to them. We try to understand what's going on in their life. Not just as, not just to be friendly, but we're also doing it to recognize opportunities to help them make changes that they might want to make. And then we consider it a treatment continuum. We do the supplies, but we also do the testing. We're about to start rolling out MAT in our public health offices, which we think will be a very popular service. And then just all of the support services that might help push a person or pull a person towards going into recovery. We do those things. So employment, food, transportation, housing, IDs. We're very strong about maintaining relationship with our communities, other agencies within the community that provide those services. And we also don't do too much data collection. For the most part, we do 4 surveys per year. Each survey has no more than 7 questions, can be done in 30 seconds, and it's focused on one topic. And we use that data to be able to inform what we do in terms of service planning. And we use a lot of incentives. Cash works, but cards as well. And we try to, pay for the services or for the data that we're collecting. And then also sometimes for example, we have a very high syphilis rate in our state. We're #1 in the country. So we're trying to encourage people to come get tested for syphilis and get treated through our harm reduction programs and incentives. We use them just like we would do for HIV. Social network strategy, so a person can get an incentive for them getting tested and also bringing other people to get tested. We also list all of our services on a website. There's 2 different websites, nmharmreduction.org, which is the one you see here on the left, where people can order free naloxone and they can find out where they can get syringes and other works. And then we have the NMHIV guide, which also provides that same information, but also things for Hep C testing and treatment, HIV and STD treatment and testing. Some of our challenges, our corrections program works for state facilities, but our local and county facilities are all individually run and there's no agency that sort of oversees them. So the engagement there has been a challenge because they also too have leadership turnover. So it's the same challenge we have with some of our native communities. Like you might get somebody who really wants to work with us and then 6 months later they leave, and so you have somebody who's not as forward thinking. But we are working on ways to engage those facilities, and also people who are returning to the community who are on treatment, making sure that they get navigated within the community once they get out to continue their treatment so that they can maintain sobriety. And then, of course, I mentioned some of the mobile homeless units, and then there's not a lot of substance use treatment centers that provide Hep C treatment, so we're working on maybe improving that process. I talked about Project HEAT. It's very simple how it works. Somebody comes into one of our public health offices or one of our providers, doesn't have insurance, they can email me the application. We can usually get them approved within a day. And then they're eligible for insurance and they can start treatment pretty much right away. And then because of the 340B mechanism, if the insurance, there's a difference in cost, and so we get a little bit of revenue from that. So we can just, this is a self-sustaining program. It's really nice. We have lots of treatment partners around the state, all of our FQHCs. And then we've had so far 19 patients come through that program. Of those, 9 have achieved SDR that we know of. There's 4 more in the process of getting treated. A couple of them are lost to follow-up and 1 passed away before they could complete treatment. But generally we have good results for this, and we have three new patients that are on the docket. So I love this program because it lets people who, you know, otherwise just wouldn't get treated come in and actually not have to pay either. So those are our programs. Love to just answer any questions you may have. Thank you.
Thank you so much, Andrew and Tennysa. That was a really, really great overview. I am trying to keep track of a couple questions in the chat here, but I'm sure folks will chime in as we dive in here to discussion. So, you know, many of us have drafted elimination plans as directed by 2103. And we're really, you know, from the presentations, interested to hear even more about the implementation side. So I'll just start with the one question that Andrew got in the chat before I dive into some more specifics. And please interrupt us if other questions arise. But Andrew, you got a question about tracking the extent of injection drug use, that 80% reduction that you had mentioned.
So it's pretty simple. Every time somebody comes in for services, we record their code, which is 4 letters and 2 numbers, and then the number of syringes they brought us, the number that we distribute. And if they got other supplies, we mark that down as well. So there's a safer smoking and snorting kits. Then there's a column for if they got a referral. So there's like 10 different referral codes. And that's all we collect. But what happened is in 2021, we distributed 12 million syringes. 2022, that was 6 million. And 2023, it was 3 million. And so it was really easy to see that data in what we collect and without any extra effort. So like I said, we try to collect minimal data. If somebody comes in and wants naloxone, we do do a little like 5-question survey to see, did they use it? When did they use it and where? Did they use rescue breathing? Did they call 911? And was the person okay? And so that's how we track the naloxone data. But it's very simple and it takes almost no time. And there's no interview or recording, and it's also anonymous. So with their code, it's based on their name and the birth year, so everybody can remember their code without even having to think about it.
Thank you. I did also put the link in the chat to this February 2024 MMWR. Many of you may have seen, and I saw it linked in the 2022 CDC data report that came out today. So, you know, this additional data, in addition to what Andrew was talking about, that some of us may not have access to. Unfortunately, at least in Pennsylvania, we don't have legalized syringe service statewide. And I know there's a few other states in that same boat, but for states that do have legalized syringe service, just a quick question, does anybody else have access to similar information as to what Andrew was alluding to regarding routes of transmission noted by the SSPs? So yeah, it might be something to definitely, you know, investigate further. I know I'll be doing so on my end. Go ahead, Andrew.
Say this, it sort of changes from region to region. So we know that the heroin gets, you know, transported up to Espanola before it's distributed to other places like Denver and Albuquerque. And In our southeast region, it's oil fields, so we have lots of meth use and not so much opioids. So there's still a lot of syringe use down there, but even that is smokable. And we also just try to educate folks that it's less dangerous if you smoke or snort something or booty bump it or whatever than if you're injecting. And so that messaging didn't take hold when it was heroin, but when it changed to fentanyl, nobody wanted to inject that because it's coming in a pill. Then you have to filter the pill. It's pain. It's also very, very dangerous and cause a lot of overdoses. And the fact is, people don't want to die, so they change the way that they use the drugs.
Thank you. And I see Larissa added the New York State tracks syringes exchange at their SEPS. So thank you for that, Larissa. So I'm going to start with some general questions here for both Tennysa and Andrew, and then I'll dive into some more nuanced questions that I had for each of you. But we'll start with how have you kept stakeholders engaged as you move from the plan development phase to more of the implementation phase? And why don't we start with Tennysa? Yeah.
Okay. So as I mentioned during my presentation, we had a lag in time between completion of the plan and now when we're starting to implement it. So on the hepatitis C side, what really helped us was getting the HE tag started. So there was already momentum, and now they've sort of, they're focused more on the task forces, but sort of that kept them going. It was a little bit of a buildup to get people involved again with the task forces if they hadn't been involved in the HE tag. And it was just sort of once we got them all together and they started going through things again, sort of that passion came back up and people really started becoming involved again.
And can you expand a little bit upon how the task forces are run? Like, is it your Department of Health staff, sort of managing each of the 4 meetings, or is it more on the partner end?
It is on the partner end. So we have the chairs of each committee are responsible for getting the meetings together when they want to meet and setting the agenda. And then they report out to the sort of like the key stakeholder, main stakeholder group, which is a more condensed task force. So it's really, we're involved in terms of like making sure that it happens, but the real work is on them.
That's helpful. I think that at least in Pennsylvania, we've been hesitant to put too much ownership, I guess, on our stakeholders or partners in the management of some of the meeting running. But I think it's a good model to, the onus has to be shared in a way. So I think that's important for folks to hear.
Yeah, and we don't really have a choice. Our staff is so small that there's no way that we could be in charge of that.
Yeah, makes sense. So I see some questions in the chat, but let's first go to Andrew to answer the question of like keeping folks engaged between development of the plan and implementation.
Yeah, I honestly don't know how we would do it if it wasn't pre-existing before I got here. But we have such good leadership from Project Echo and UNM. And then our Medicaid folks are really good too and want this all to work. It is driven by us as far as making the agenda, but we kind of do a round robin. The way I like to make the agendas is to include everybody. So we want all the MCOs to present to us every year what they're doing. We want Project Echo to kind of give us an update on, and Corrections Department on their project. We really don't focus too much on the vendors as much because they do what they do, but we like their support. But sometimes they have an innovation we would like them to share as well. So Yeah, it's really very cooperative and, just try to give everybody a voice. And we've also had presentations from the peer educators and the folks that work with them. So it's just an inclusive process. And then, a lot of times we get requests. Hey, we have this thing we want to talk about. We want to open a clinic in Roswell. So let's have the group discuss what are the ins and outs of that. So it's pretty participatory.
That's great. Thank you. So we'll go to the one question that I see in the chat remaining. And I think it probably is a question for Andrew here. Have you had any issues with legal authorities detaining clients for having paraphernalia which they're permitted to have from a registered SSP? And if so, how has it been handled?
So yeah, we certainly have the immunity coming to and from services. One thing that's helped, well, so start off, we work with the state police and the training agency for the state police. So they have received our training. We have a harm reduction specialist training that lasts a full day. And so we have made some state LETI, which is Law Enforcement Training Institute, who trains all of the state police around around New Mexico, understand and then distribute that information to the police force. Sometimes we do have some local police in various conservative areas, and even in Albuquerque, where it's well known our program should be around. It's usually not that they're arresting people for paraphernalia. Also, there's been a de-emphasis on, it's a $50 ticket now. So it's really just an add-on charge that it usually gets, then we can write a letter and it gets dropped if we know which judge to write it to. And so we tell all of our service providers to remind, and they also have to carry a card with them. So if the person is carrying the card with their code on it, generally the police know not to charge them with paraphernalia. Now, of course, we remind people, don't carry a loaded syringe and don't carry your bag of whatever you have in your pocket. So we remind people that that is a risk for them. So the only thing we can do is get them off those charges. And the truth is we haven't had to do it except for in one case where the police came and arrested a person who had warrants who was standing in line. We can't really do anything about that, but we can work with the police and remind them not to harass our folks. And if that happens, which it did happen a little bit recently, we just get with LETI and have them go do some training with the local police force. And then hopefully the policies will change at the local level.
Thank you. So next I wanted to explore, how you have engaged with folks with lived experience around plan development and of course the implementation phase. And Andrew, you alluded to some incentives for data collection, but I'll start with you with this question.
Yeah, so I'll say this, it's hard to get people with Hep C to become advocates because number one, if there's substance use there and they get cured and they feel better, they really just don't want to become part of our team. Like, it's not like HIV where you have a lifelong diagnosis and you want to become an activist, This is where you get cured, you feel better, and you go on your life. So it's not that we have a lot of participation, but because we do have the harm reduction programs, we can tailor some of those little, we call them point in time surveys. They're very short. And so we can ask people about what their experience of either getting tested or treated was through that mechanism without, having to go out and really dig. Because people are coming in for services anyway. It's just like another extra minute they have to stay to tell us those answers. But we don't really have folks that come on our planning meetings or our monitoring meetings on a regular basis.
And just one quick question before I turn it to Tennysa. So interested to hear more about the peer project with the Department of Corrections. How is that funded?
Good question. It's done through Project Echo, and I know we do support that. So there's it's to pay staff to be able to engage the peers and do the training.
Okay. Thank you. And that sounds like a great mechanism as well to get folks involved somehow. So, Tennysa.
So during plan development, to get the input of people with lived experience, we sort of went outside the task forces. We had some self-identified people on the task forces, but to really get a good sampling, we did focus groups and we did surveys, and those we did use incentives so that we could get people involved. And we had a great response from that. We had, I can't remember off the top of my head, but we had multiple focus groups, and we got really good information from people. As far as the implementation, there hasn't been anything specific done except for those people who self-identify who are on the task forces already. So I imagine it will have to be something like surveys at our SSPs and that kind of thing. Yeah.
Thank you. I'll just pause here for any additional questions from the audience related to kind of those two first general questions that I asked. All right. Well, I did want to ask a little bit more of Tennysa about, the integrated approach with HIV, and I know some other states have gone down this road as well. Can you talk through, I think you alluded to it a little bit, but some pros and cons, for lack of a better word, of sort of going this integrated route? You mentioned that, at least some of the task forces, are more focused on HIV. How do the HEP members, feel about that, or how have you sort of bridged those gaps?
We're very fortunate to have multiple people in the state who are really passionate about hepatitis C. And they sort of made sure that hepatitis C was represented. You see a lack of it a little bit in terms of the prevention and the elimination plan. We've really had to work hepatitis in there just because there's so much available for HIV that isn't available for hepatitis C. So it really came down to those champions. Without them, it would have been a lot harder.
Thank you. And Andrew, how has collaboration been with the HIV side on, their planning, and if at all, in collaboration with the Hep C plan?
Well, of course, they did their own plan, so they're separate, but we actually office right together, and just about everything we do is coordinated just because of physical proximity, which is great because lucky because we're a small state. We don't have local jurisdictions that have their own health departments, so it's all centralized here. And we're all in one section together. So it's kind of a natural fit. And another example is we were #1 in syphilis. And so we realized, we can probably do testing at our SSPs, and our public health offices already do. So it's just a natural fit. And we try to just, we have these meetings, and like right now we're at the HIV planning meeting. The HIV people come to our meetings. And so we all know what we're doing, and we know we can identify problems when they occur, and just work together.
Great. All right. So next I wanted to ask about keeping partners accountable for activities that they've agreed to complete or help to work on. In Pennsylvania, we tried getting our sister agencies to sort of sign an implementation plan. And we did get one to actually physically sign it, and that's our Department of Drug and Alcohol programs. And I think that has fostered a better relationship. And I was actually encouraged to do that by some federal partners conversations a couple years ago. So I wondered, on the West Virginia end with the task forces, how has that sort of accountability worked? or anything else you can say about sort of sister agency collaboration too.
I think a lot of times what we see is that they are focused on making the plan and these are the activities we should do, but there is difficulty in getting the actual activities happening. As I said before, those champions that we have are really key for us in hepatitis C and getting those things moving forward. They are not afraid to hold people accountable on their own. So far, and we're new in it. It just started in February, but so far they've been able to handle that without us sort of stepping in. It's harder. Those are our community academic partners. It is harder, I think, state agency to state agency, which one would think that would be easier, but it's a little bit harder to get them. I think just because of the way the state system works for all of us, it's hard to get anything done.
Thank you. Andrew, anything else to add there?
Yeah, I would agree with Tennysa on that. It's easier to get your contracted partners to do things than it necessarily sometimes with your owner or another department, because we have a contract. One thing we do is have a harm reduction echo as well. It's not a normal echo because we're not doing cases, but we do, various topics. So maybe next month we'll do human trafficking and try to update people on that. But then we also have sessions where we say, okay, let's look at your testing numbers and see what we can do to provide technical assistance. And if it doesn't work from a call like that, then we'll go out. And really our team is technical assistance. That's what we do. And so we'll just pay a friendly visit and say, hey, what can we do to help you get more people in the door to do testing, to do, are you talking to your clients enough? And we'll just observe and just, do it that way directly.
Great, thank you. To the group as well, any thoughts about accountability of partners that are engaged in this work or sister agencies? Any lessons learned folks want to share? It's definitely a hard thing to, push or ensure. So I appreciate the comments to this and Andrew. So we have two questions in the chat. One's from Isabel. Heard that, momentum tends to wane after the plan is finalized. What do you believe are key strategies or activities that keep folks engaged and energized?
Sorry, I can go first. I think for us, as I said before, it really is about having those champions. And I think if you can move quicker from development and finalization to implementation, I think it would be easier because of the lag that we had in time. It really is down to those champions and their passion.
I would just say, I think my last answer kind of addressed that. We do have those regular meetings and offer technical assistance to people who aren't meeting the goals that they set. And we haven't had too much trouble with it. It's just sometimes people if it's a new service, they may not understand exactly how to promote it or how to get people to accept or to take on that service. So it's really, a friendly process, but it's also regular accountability and if necessary, face-to-face.
So this question is a little bit in the weeds, but related to your comment about getting some testing data from your partners. Those are contracted partners, I assume, and would the testing data be part of the contract that they would have to provide that?
Yeah, so we moved to where we have public health offices and nurses. We really don't do rapid testing anymore, so it's lab. So we can rely on the lab data to provide that data. But with contractors who are doing rapids, we make them keep a log and report back to us. So for syphilis, we also have to add that they need to report that immediately to our DIS so that they can do the interview and refer people to treatment. And we also let them use incentives to ensure the person gets the incentive after they've gotten treated. in addition to just getting tested. So that kind of, it works. People want to get that money, and, if we have to pay people to get treated, we will.
That's awesome. Yeah, thank you for that. One question in the chat, is there any issue with people wanting to get tested for Hep C at sites focused on people living with HIV and people not in care for HIV, not testing for it? Do they have to be referred to another testing site? So a question for Tennysa or Andrew.
We don't have an issue with that. I'm kind of unsure about the question. So do some people have testing sites solely for HIV?
Well, I think, and Linda, speak up here to clarify, but I've heard, from certain partners in Pennsylvania that, sometimes folks will only want to get tested for Hep C. They're not ready yet
Okay.
to
Okay.
handle the HIV.
Okay. I think most of our folks are happy to be tested for both if the presentation is right. So at the SSPs where they have a better relationship with people, or for instance, we have a program with peer navigators that go out. The people that they see are really thankful to be tested for both, but that's because of those personal relationships.
Makes sense. And Andrew, if you want to chime in here, looks like Linda was referencing some New Mexico stats too.
Yeah, most of the places that do have HIV testing are also doing Hep C testing. So, I mean, I haven't heard of any problems with people not offering it. I'm not sure exactly where that concern is from, but most of our locations do offer both. And if the person wants it, they can have it.
Thank you. And thanks to Kyle for the input about the expectation that Florida sort of had at the beginning of their work with partners. So that's helpful from the very beginning to kind of set that expectation that we're going to work on implementation, not just planning. All right, so we're about 2 minutes. And Isabel's adding, curious to hear more about history with New Mexico's relationship with tribal nations. I'm sure that could be an entirely different talk, Andrew. But anything you want to add, Andrew, at this point?
No, I mean, it's all about leadership and, engagement with the leaders of each tribe and treating them with the dignity and respect. One of the things that we do very well is hire people from different communities. So we have people from the trans community in our department. We have people that are Native and, can really not come in as an outsider necessarily for those communities and build those connections. But it's not easy because if leadership changes and there's just so much historical trauma, you have to be patient with the pace of change and just stay engaged. And we do have plans, I'll tell you, to hire more liaisons for both of those communities. So as that happens, I think we'll maybe get a little more traction.
I think that's the lesson with all partner engagement, just to stay patient and engaged. So the last question that I have is about your work with advocates. And, this again could be an entirely different talk, but anything you want to say about the engagement with advocates on implementation and or the planning phase?
Just say, listen to what they say. In harm reduction, it's nothing about us without us. And that applies to Hep C planning as equally well as it would for harm reduction.
Sounds good. It looks like we got one more comment here. Making the plan released into more of a public occasion can be important to create community stakeholder and political engagement. New York City viral hepatitis elimination plan was published between Christmas and New Year's, and it was to get that out, and in-person or virtual rollout could have been more impactful there. So that's a good note. Thank you, Reed, for that. It looks like we're at the top of the hour here. So thank you again, Tennysa and Andrew, for your wealth of information that you shared in the discussion. So Thanks again for the invitation, Zakia. Pass it back to you.
Oh, yes, I just wanted to echo that and thanks everyone, our presenters, our moderators, everyone for asking questions in the chat. I don't know, it was a really great session and I feel like I don't know, I'm just like bursting with ideas and hopefully you all are as well, of seeing how we can get these plans from plans to implemented to fully executed. Probably not, but we can try. So thank you all so much for your time and for sharing all of your experience. And we'll see you all like actual in person soon. So that'll be awesome. But then we'll see you for the VLC on April 26th. So thank you.
Thank you. Bye-bye.
Bye.